So in keeping with the theme of the cause finds the cure, we're going to talk first a little bit about the history that got us here and think through why we are thinking the way that we are thinking now, and then bring it into the present, and then end with what we're expecting for the future. So first, I'd like to introduce our panelists. Would each of you introduce yourself, your institution that you are from, and your primary area of interest, please?
So I'll start first. So my name is Vincent Van Rompey. I'm an ENT surgeon, of course, from Antwerp University Hospital in Belgium. An area of interest is specifically, of course, cochlear implantation and genetic diagnosis and genetic testing.
Hello, my name is Lassaletta. I'm an otologist at La Patria University Hospital in Madrid, and my areas of interest are auditory implants, the facial nerve, and vestibular schwannoma.
I'm Griet. I'm an audiologist from the same team as Professor Van Rompey, and I did my PhD in 2015. I defended my PhD on single-sided deafness, so I'm happy to be part of this panel today.
Hello, my name is Anita Obrycka. I'm from the Institute of Physiology and Pathology of Hearing. I'm an audiologist, fitting specialist, and research specialist, and I'm mostly now interested in binaural effects, so happy to be in this panel.
It's a nice blend. Okay, so first we're going to talk about how did we get here. And thankfully we have two folks from the Belgium group, and we know that that's where we've learned a lot. So first, Griet or Vincent, would you tell us a little bit about how it started?
Yes, so it started in 2004. Then the first patient with single-sided deafness was implanted in the Antwerp University Hospital. So that was before the time that I started working there. I only started in 2011. And at the beginning, there was some resistance of implanting patients with single-sided deafness because it was not sure whether a cochlear implant can integrate with the acoustic input from the contralateral side, whether binaural effects were able to be restored. But luckily, the aim of the first study in Antwerp of Professor Van de Heining was not to restore those binaural benefits. The main primary aim there was to suppress the tinnitus in the single-sided deaf ear. So those patients, their major complaint was the ipsilateral incapacitating tinnitus. They were not asking for restoration of the hearing, but really to reduce the tinnitus. So that was nice to see that indeed in this initial cohort, the tinnitus went down, and as a secondary outcome, we there observed that also binaural effects and hearing improved as well in this cohort.
And I really liked the study that went into the details about mapping. Obviously, mapping is the coolest part when we're thinking about this. But how it started with just the basal region, how she was activating just those most basal channels, saw that tinnitus was suppressed, and then slowly increased, and then activated the whole electrode array. And then that patient ended up liking the sound quality, which was not expected. Is there something you were going to add to that, Vincent?
No, I think, and Griet has some data that will hopefully be accepted in a while, because it's for and the review currently the manuscript of over 20 years of these patients that we are following up, and I think that even those were the first patients, still 92% of them still use it. So I think that we learned a lot, despite that there were some hiccups, of course, and I think that Paul can explain more about what are in fact now the contraindications like depression, active depression. So I think that we learned a lot from these early cases, but still, despite being the first cases, user rate is quite high, and I think that we've learned from other studies, which we'll be discussing in a while, I think, that it's not always the case.
So what were some of the initial outcomes of patients that you have seen, Louise, when you first started doing cases of single-sided deafness?
So going back to your previous comment and related to this one, I'm older than you guys, so I was here when we had all this research going on, and Paul shared it with us. And then I remember that he was always telling us that as he was a little bit like afraid of what he was doing when he started to see the outcomes related to the hearing improvement, he always insisted that, keep in mind that we are only implanting them because of the tinnitus. And then, like, the improvement in hearing was like a secondary goal. So I think that in the initial outcomes were tinnitus suppression, of course, but then in these first studies, as a secondary goal, we started to see an improvement in the hearing too. And I think there was also what we are looking for as a general rule in these patients, which is improving localization and improving hearing in noise, but always at the beginning after the tinnitus suppression.
Anita, would you add anything to our history lesson?
So maybe I would just add that we also started with tinnitus patients, and a little bit later than the group from Antwerp, and we also saw the benefit instead of tinnitus suppression, and we were more and more confident in implanting also patients without tinnitus. And our first study group was only 6 people without tinnitus and 15 with tinnitus, and we didn't see any difference between those groups. So this was really something that made us go further than only tinnitus for a single-sided deafness.
Speaking of the tinnitus part, have you guys had anyone whose tinnitus has gotten worse? Who pursued it for that reason and it got worse?
In all of them, the tinnitus went down when the CI is activated. However, if you compare the pre-op visual analog scale score with the off condition after surgery, there are some patients that have an increasement in tinnitus loudness. However, they are still very happy because they have the control to reduce the tinnitus when they switch on the cochlear implant. But
which was the message that was being received. And so I remember Dr. Van de Heining one time presenting this and thinking, oh my gosh, we've gone too far, right? Why would anyone implant somebody with a unilateral hearing loss? This is too much. But we had a patient around that same time pay out of pocket to suppress his tinnitus. Like, that was his primary goal, and then the tinnitus got worse. And that caused a little fear on our side of whether that should be the primary motivation for pursuing a cochlear implant.
Yeah, and just want to add that, of course, for tinnitus, there's a big difference between tinnitus visual analog scales and like the control, perception of control is probably for the patient more important than the actual visual analog scale. So I think that we keep the control of the tinnitus. I think that's the better part here. Yeah.
Okay. Anything else that we want to add on the history before we move to part 2?
yeah, maybe there we will discuss this later. The counseling is very important, but when we are talking about the tinnitus, we also counsel already prior to surgery that there is a possibility that right after surgery the tinnitus loudness will improve a little bit. But once the CI is activated, it's a very early effect that we observed, then the tinnitus loudness will reduce. But and that's maybe also motivation to go for a little earlier activation and not wait the 4 weeks or the 2 weeks, but maybe go a little bit earlier.
Okay. All right, so part 2 is where are we now? Let's start with the candidacy evaluation. What do you currently evaluate when assessing candidacy for cochlear implantation?
Well, I can start from the medical side. First, I want to know whether, in fact, there's a cochlear nerve and the cochlea can be accessed, of course. But I think that Griet can explain a little bit more because I always send my patients to her. Then to actually evaluate them and explain a little bit more from actually her experience following up all these patients. I think it's very helpful. And we have, of course, we will have reimbursement starting in January, but up to now, these are patients that have private pay out of pocket. So the issue is that we want to make sure we explain them very well, that we manage their expectations, and then I think they need a more personalized interview with Griet. So I think that she can explain a little bit more what we use for the candidacy.
So maybe we should just pause first. So what are the approved indications, and is it approved for children and adults in each of your countries?
So in Belgium, we have, for single-sided deafness, there is an approval in children since January 24, for prelingual up to 4 years of age, and for acquired up to the age of 18 years. although it's 85 decibels or worse. And then for the adults, we'll have reimbursement starting January, but the duration of deafness can be up to 7 years. We don't know why, but it's up to 7 years.
So in Spain, we wouldn't have like strict regulations about that, and no problem with reimbursement. So it depends on the criteria of each institution. So we consider this not like an established indication of CI, but like an emergent indication of CI. But if we find that the patient is suitable, we don't have the reimbursement problem.
In Poland, we don't also have any limitations to the age of patients, children, so it all depends on our criteria, on our qualification procedure.
The 4-year cutoff is interesting for children. In the United States, it's 5 years and up. That's what the approval is, and I think many of us, maybe I shouldn't assume that, and that should be a question for the panel, but would think that that's too late if they're a congenital loss. That we've really missed that window of where they could have the maximum benefit. And then yesterday, I had mentioned that Medicare, which is the coverage for patients that are 65 and up, currently does not support single-sided deafness or asymmetric hearing loss for their beneficiaries, which is unfortunate. Okay, so back to what do you consider when you're thinking about candidacy? What are you assessing? What are you weighing?
So in our clinic, we are doing mostly the same assessment as for normal cochlear implant candidate, with the focus on cochlear nerve presence, and in children, with the focus with additional disabilities as well. And we need to take into considerations, especially I think the most something that we look at in adults is the onset of deafness. So if a patient is saying that the deafness was since early childhood, we always have to bear in mind that it could be prelingual, and in those cases we don't have observed benefit after single-sided deafness. So this is something that is difficult and tricky, the onset of deafness in adults.
In Madrid, I think we need to do a very thorough clinical history, especially looking at the duration of deafness and the age of onset. I think that, and also the etiology of the deafness. I think that those are the 3 key points. Then, from an audiological point of view, just if it fulfills the criteria of SSD, we can do some other tests, but mainly for research. Then imaging, just to rule out we don't have a cochlear nerve deficiency. And then I think that the most important part is counseling. So when you have the candidate, you don't have a clear contraindication, both in children or adults, then the counseling starts, and I think you have to go through all the pros and cons and motivation. And I think it's that the hardest part, because especially for children, we are telling them at the same time that it's unclear, we don't have very established prognostic factors. You were talking about duration of deafness or age of onset. We don't really have a cutoff. We have some doubts about performance, but at the same time, we are also telling them that as soon as they do it, theoretically, you will get better outcomes. So that's a big pressure for the patients and especially for the parents. Mm-hmm. So I think that the most important part is the counseling and to be sure about the motivation and the kind of patient that wants to get the implant.
Mm-hmm. I agree with all the panelists, and maybe I want to pin one other thing is after we've got the patient from Professor Van Heining, Professor Van Rompey, and Professor Lammers, then there's first an intake interview of 1 hour And then the CI trajectory starts. It's multidisciplinary, also with a psychologist, and especially in patients with tinnitus. There we use the HATS questionnaire to assess the level of depression and anxiety. And I think this is a very, very important step, especially in patients with single-sided deafness. It's like Professor Van Heining always says, cochlear implant is not a treatment for the depression, but it's a treatment for the single-sided deafness, the tinnitus reduction and binaural hearing, but not to treat the depression of our patients.
Is it just for the patients that have tinnitus, or all patients
of them,
with that?
yeah, the single-sided deaf patients with and without tinnitus, and also in our patients with bilateral deafness. Yeah, it's an important step.
Yeah.
And also with the prelingual, so more often nowadays we see children, very young children, like 6 to 9 to 12 months with labyrinthitis, meningitis. And I think also you need to make sure that your pediatricians, ICU people are aware that they need to notify you of this and that you need to manage these cases, have ear-specific testing, often just ABR, which is very difficult, of course, because these children are on ICU. So this requires really also an individualized assessment. So and also then, of course, these cases are more difficult to implant. But yeah, we'll get to that in a moment, I think. So sometimes we see severe infections with like erosion of the cochlear bone, with erosion towards the internal carotid artery. So these are things that we need to manage, whether it's safe to do a single-sided deaf child with possible dislocation of an electrode towards the internal carotid. So these are things, it's maybe different in a bilateral deaf child with respect to single-sided deaf. So these are options that you have to discuss as well with the parents.
So for children, what's the motivation when parents are coming in and saying, or if they're older children, what is the motivation to pursue cochlear implantation? What are they saying?
So for sure there is an issue of this binaural hearing and problems with auditory development, to perceive, to take advantage of all binaural effects. And this is the same motivation as for adults, to hear better in noise, to localize sounds. We know about the consequences of single-sided deafness, some problems in the school environment and psychosocial relations. So this is also motivation. But we also see in children the fear of parents that children can lose their hearing in the other ear, especially in congenital CMV infections, when it is possible that the hearing can deteriorate even in the normal hearing ear. So this is something what we observe in children, that the fear that child can lose hearing in the normal hearing ear.
I totally agree. I just wanted to add that in the 21st century, the parents don't allow for any problem with their children. I mean, they want them to be the best in their classes, to speak multiple languages, do all sports, and then having like a small problem is something that they don't want to tolerate. The problem is that on one hand, we know that the theoretically problems that a child with single-sided deafness will have, but on the other hand, we know lots of people that manage very well with one ear. So they also are afraid of stigma and making a normal children a patient. So I think you have to balance all of that, adding the pressure I mentioned before about the timing, and then having all the information they will go for it. And I think the main problem here is that, as you mentioned, we don't have a real cutoff for the age. And we have had some experiences in the literature so far that institutions, especially in the States, that they were just implanting all the children, and they have now more than 50% of non-users on the long term. And that's a problem too. So to find a balance in pushing the patients for going for the CI for their parents and waiting, it's really difficult because this lack of cutoff so far.
Mm-hmm. So thinking about non-use in that publication that you just referenced, and this is something that we'll talk about in just the next slide, but they did have the criterion of if it was 6 hours or less, then that was non-use. And I think with patients with bilateral hearing loss, we might be willing to consider that, but do you see differences in duration of device use or daily device use for patients with single-sided deafness, since the need and the motivation to wear it might be different for somebody who has a normal hearing ear as compared to somebody who has bilateral hearing loss?
Of course. I mean, it's normal. You don't need the implant for your daily life, whereas when you have bilateral hearing loss, you really need it. So it's logical to have, I mean, I'm not saying it's logical to have some non-users, but here you're mixing like performance and motivation, and you cannot predict that beforehand. That's what I mean.
And the point there that I'm making is 6 hours or less may not be non-use. That's limited use, but it's not non-use. I would say non-use is you've stopped wearing it completely. And we have some most of what I see are adults, but they'll wear it 6 hours a day, on your data logging, but they still see incredible benefit from it. And sure, if they wore it longer, they might have greater benefit, but their motivation for what they need it for, they're very satisfied with their device. So just as a point of conversation. Now, before we get too far into that, I do want to bring up something that we talked a little bit about yesterday. We sort of danced around it, and then we didn't really answer. But is device selection similar? Well, first, I guess, who decides on the electrode array at each of your practices? And then depending on that, is it different for somebody with single-sided deafness than it is for patients with conventional candidacy?
In Warsaw, it was the surgeon's decision to choose the electrode based on the CT scan. And in profound hearing loss, and if the anatomical conditions are okay, we are trying to use the long electrodes to cover the whole cochlea.
I think we are, as a group, in favor of long electrodes, but I think in this particular subset of patients, especially, I think we have to try to match the other ear as much as possible. So I think measuring and placing the longer electrode possible in SSD is crucial, because then I guess you get to that, the fitting, you can do it better to match the other ear.
Yeah, I agree. So, of course, we decide with the patient which type of device, but I think especially in these cases, deep insertions is really important. I think we've seen nice results, but also when there are cochlear devices used, then you see that there's 20% of non-use rate at 24 months, so or even explantation. So I think it makes sense then to, if you want to evolve towards natural hearing and comparing it to other ear, this will make even more sense. But essentially, it's the same philosophy.
You can say?
Maybe a very small comment to add. In patients where we would like to do an ANTS measurement, for example, there we would go for a CI system that has the ANTS measurements available in those single-sided deaf cases with schwannomas.
Would you ever not recommend a cochlear implant for a patient with single-sided deafness, child, adult? What's the motivation there?
So for the children, and we've had this issue with, despite psychologists, social worker, even audiologist at home, in a single-sided deaf child, that if the parents are not really interested any longer or lose interest, this is a major issue, and we can be on them with the team and follow them, and rehabilitation is involved. But then it's a real issue. So we are upfront very transparent that they are essential in fact just putting the implant on, the processor on. So if there's any doubt, we really want to make sure, and for now, of course, we cannot predict that, but we have had experience, and it's very difficult in these cases. Yeah.
So I think I wouldn't recommend a cochlear implant in two categories of patients. One related to motivation, as we were saying before. So I think it's not me recommending is the patient asking for a CI. They have to really motivate it. Here we are talking about like conventional SSD. And then the other group would depend on the etiology of hearing loss. So for example, I mean, you have like etiologies like push against CI or push forward. So pushing forward would be, for example, infection CMV. We were talking about that yesterday. You have this concept of fragility on the other ear. You have the option that the other ear can get worse at that time. I think that pushes strongly in favor of placing an implant. I think the same happens talking about schwannomas when you have an NF2 patient, especially if you can implant instead of an ABI. That's a strong thing. And on the other hand, you have, for example, cochlear nerve deficiency. We were talking about that yesterday. I think it's not an indication. So if hearing is normal on the other side, I wouldn't consider it. And cochlear malformations, although it's a very, very simple malformation, maybe EVAS or IP2, I wouldn't consider going for a CI in those cases. And then we have, Griet mentioned the schwannoma group. That goes completely apart from that. But even in those cases, I normally consider only placing a CI if there's some kind of contralateral hearing loss. I mean, if hearing is completely normal, I don't think if a CI is an indication as a general rule.
All right, so they get their cochlear implant, now they're seeing us. What outcomes do we expect? What are we telling patients that we think can happen if they're your run-of-the-mill SSD?
If we are looking at our cohort of 78 patients for now like 20 years of follow-up, the first benefit that we observe is in the majority. I think in all of them, except for 2, they were having tinnitus before surgery. That the tinnitus reduction is the first benefit that we observe. Then the sound localization improvement, that's the other one that's very early onset benefit. And then it takes some time to have those binaural benefits, and they really have to train at home, but then you can also observe the binaural improvement in speech perception in noise. Yeah, and another benefit that we were also mentioning during the audiology session is the effect on music enjoyment. We know that with a cochlear implant, the music enjoyment is very poor still. However, those patients with single-sided deafness, and we did a study on that together with David Landsberger, showing that having one normal hearing ear, the music enjoyment is less without the implant on. So when you turn the implant on in the single-sided deaf patients, the music enjoyment is going up, even if it's a poor music perception. So it's also beneficial for music enjoyment, I think.
We also expect, of course, the subjective assessment, improvement in quality of life, and in, for example, we showed that also in SSD patients, it is possible to measure the quality of life improvement with AFAB questionnaire. So we also expect that not only we, specialists, audiologists, can see the benefit, but also patient can feel that cochlear implant is beneficial.
Are there certain variables that you want to monitor over time?
Device usage.
Okay.
Yeah, this is really crucial to monitor how long patient is using the device. It's of course dependent on the lifestyle. So as we discussed before, it is possible to function with one ear without cochlear implant. If a patient is really very active, there is no issue on device using, but some people are, let's say, spending most of the day alone at home, so they want to save batteries or some other reasons. So we need to monitor the device use, and we need to counsel them to use cochlear implant and how it is important. And also to monitor the other ear. It is also important.
Are there any mapping procedures that you do differently for this patient population?
If the definition of mapping and fitting is really just Maestro-based, then I would say MCLs and everything I do in the same way as I do for bilaterally deaf patients. But here we are really focusing on the anatomy-based fitting, especially after the publication of the group of Würzburg, showing that in single-sided deaf patients, after a trial, that all the 12 patients were choosing anatomy-based fitting, and that also the speech perception in noise improved in the ABF condition. So here I would say for mapping SSD patient, definitely go for the anatomy-based fitting.
We also check the direct input from the, we check the speech discrimination with direct input to the speech processor. So this is something which is not usually done in traditional CI candidates, to just confirm that we have some direct speech recognition from the CI.
I think this question is related to the previous one. So I think we are in favor in these cases of long electrodes, deep insertions, which are the cases that go best with ABF. And we see benefit in all the aspects that Griet just commented, and especially with music. I think in this particular subset of patients that they really tell with the ABF that the music sounds more natural. So I think we cannot do it with the older patients because of the processor, because with the sound processors that are compatible with ABF, I think this, no question that we will go for that feeding method if possible.
Yeah, maybe related to the first question is that we also observed that with respect to productivity and work, we in fact saw that in the unilateral, so single-sided deaf patients, that it's equivalent to bilateral hearing loss patients, bilateral severe hearing loss, and that the impact was over 30% of loss of productivity, probably due to the lack of sound localization. So I think that we are now conducting a prospective study to evaluate productivity and work 1 year after CI activation. So I think probably it might be something that also health authorities and government are interested in, while increasing the amount of people that are at work. So maybe we have to do that in the future as well.
And is that data that you guys are collecting as part of clinical care, or is that part of a research study?
Project,
okay.
yeah.
Okay. The piece about the variables that are influencing outcomes, what we have seen is with data logging is that the longer you wear it, the better your speech recognition is. But then with mismatch, the less mismatch that you have with your device, the better your performance is. And we see that across manufacturers. And so that really prompted a discussion with our group, because we primarily use the Flex Soft for our SSD cases. But even with the Flex Soft, you can have mismatch. And so it is the piece of using the longer array, but then also accounting for that individual variability with the mapping. Anything else on that one?
Yeah, I think for the variables as well for insertion, if it's a labyrinthitis or meningitis, so it depends how much of the cochlea is still open. So I think that's very, very important to monitor that, because of course if you're not able to go for a deep insertion any longer, I also have the impression that for the children acquired, that we use the insertion probe a lot more because of problems inserting. So I think we also really want to make sure that we are there in the cochlea as early as possible.
Okay. And I think also the factor is the involvement in rehabilitation. So the more patients are willing to train the CI ear. This is just a clinical observation, not the study, but what we can see, with what we can observe.
Yeah. Okay, so the last part. How do we best serve this unique patient population? So now that we know the cause and we have a cure, how can we improve what we are doing for them? What are the current barriers for care for this patient population?
Yeah, I guess it's awareness predominantly. So I think that's very important towards the patients, towards the GPs. Also, if it's single-sided deafness and these are sudden hearing losses, we keep repeating that it's an emergency to be treated and trying to recover it. And of course, these are also the patients that you want to implant. And I think there also we have the question, what is the earliest we go in after sudden deafness? I think that some people say 3 months. I would say maybe rather 6 months, but that's something that I don't know the answer to. But just being aware that this is something that needs to be treated and that doesn't need to wait for a long time. So
Maybe another barrier, I'm a little bit afraid for January 2026, because then in Belgium there will be reimbursement. And up until now, it was very good patient selection for a study, or because the patient had to pay it themselves. And if a patient had to pay it themselves, they are really, really motivated to get the best out of the cochlear implant. But I think when it's reimbursed, that the patient selection criteria should be even, be more paid attention to. Yeah.
Do we have a microphone for Professor Hagen? Thank you.
So in hearing group, we like to have a consensus. And could you achieve a consensus concerning SSD that we should have a complete cochlear coverage plus ABF as a standard? Could you agree to this? This is one question to the roundtable partners. And the second one is, we expect the TICI, the total implant, within maybe 1 year, hopefully. Would this change the position of the patient to decide for a CI, because there is nothing more visible, so there is no cosmetic aspect any longer? So 2 questions.
So maybe I will go first. So I think in these cases for us it's complete cochlear coverage and ABF. That's what we do currently. So I think for us, I think that would be a standard. Second question, I think I'm not allowed to. My opinion is more that related to perception. So we see often patients that want to hide it. Not necessarily, I think you need to hide the hearing loss. I explain to people that probably it's better for you that it is visible at this point, because otherwise people don't realize there's an issue with speech understanding. So, but I don't have any data, of course, for TICI to have an opinion.
Yeah, I absolutely agree. If you look at the other way around, I cannot find a single reason to place a shorter electrode in a case of SSD, if it fulfills the criteria. So, and we've seen that ABF provides an additional advantage. About the TICI or total implantable, I think it should make something different in adults. Maybe for children, counseling with the parents is more difficult, but I think that it would be adults that would go for a CI if they had something non-visible. I agree that maybe it's not our point of view, but at least in Spain, their point of view, if they know something is going to be notable, they wouldn't do it. So I think that's interesting to add. Yeah.
Yeah, and concerning your TICI question, then I'm also looking mainly at our tinnitus single-sided deaf patients. There can be a quite nice benefit, because now during the night they of course turn the CI off and then the tinnitus comes back. But I think in this specific population, when they can keep on wearing the TICI all night long and have some auditory input, that maybe they would like the benefit even more. Mm-hmm.
Dr. Van Heining, do you have a question?
No, Griet addressed my comment too, so I have nothing to add.
One mind, yeah. Nothing there, okay. So what can we do better for this patient population?
Raise awareness, especially among, as you mentioned, general practitioners, especially children after congenital CMV. In Poland, we don't have screening for congenital CMV, and this is something we can do better in Poland, to have also this screening for congenital CMV.
In Belgium, now with the reimbursement coming up, there are a lot of people out there now aided with a cross or with a bone conduction device. And because of the deadline of these 7 years after the onset of single-sided deafness, I think we should raise awareness to not miss those patients walking around that are possible candidates for cochlear implants.
Yeah, talking about this, we didn't mention the usual trial with bone conduction or cross systems. I think that's absolutely useless. That's for what we are looking for. But what we can do better, I think, is awareness first, and second, in some way, try to learn about prognostic factors or predictive factors and be better choosing the candidates.
Yeah, difficult question. So I would say locally in our country abandon the regulations and move towards something like in other countries, like in Spain, and that we have medical indications that we think that are the best patients. I think that's a local issue. So I think that we can do better, of course, by talking about it to our colleagues that are not involved in autology or CI, talking about this on postgraduate meetings and raising awareness on GPs. And probably the most efficient is go to the patients themselves, that single-sided deafness is an issue and that we need to explain, and that they then reach out and present to their GP and ENT physician with the question that I want to have binaural hearing. So I think that's the easiest part. But of course, we do have a minister nowadays of our federal government in Belgium that wears a cochlear implant. So I think that might be the exact right timing to do that. It may have helped for our reimbursement in January, but I think that we need to just reach out to the public.
Okay.